side. Do veins usually carry oxygen or no oxygen? Look at the veins on your wrist. Are they blue or red? They're blue. Why are they blue? Because they don't have oxygen. They're going back to your heart to be pumped to your lungs to pick up oxygen. But in this case, the umbilical vein carries oxygenated blood, so it's exactly opposite. It doesn't change until the baby is born and takes that first breath.
So once the blood goes into the umbilical vein, it has kind of a branch point. You can see that it can either go to the right or the left. And if it goes to the left, it's going to enter the liver. So if it goes kind of this way, it's going to enter the liver, and it's going to take a while for that blood to come out on the other side because it has to go through all the little capillaries in the liver and then emerge on the other side. But there is a shortcut. So the shortcut, let me just circle it here. The shortcut is actually going to be right here. So let me just make sure it's very clear what that shortcut is. This is called our ductus venosus. Ductus venosus. And the ductus venosus is basically going to allow blood to go from the umbilical vein through it. So it's like a little tube. So it is just like any other blood vessel. It's going to go through it. And on the other side, it hits and meets up with our inferior vena cava. So this is our inferior vena cava, I'll write IVC, just for short. And the IVC, or the inferior vena cava, is a large vein picking up blood from the right leg and also from the left leg. So this is our left leg down here. So the inferior vena cava meets up with the blood coming from the umbilical vein, which is very oxygenated. And so this blood I'm going to draw is kind of purplish now because it's kind of got some oxygen, but it's not as rich as what was coming out initially from the umbilical vein because it mixed in with the IVC. And that blood dumps into the right atrium. So this is our right atrium on this side. And simultaneously, you actually have blood from the superior vena cava, or SVC. This is our head and arm region, draining down this way, and this blood also kind of ends up in the right atrium. So you've got this blood kind of mixing, and now I'm going to draw it as kind of a deeper purple because it's mixed up blood. Now, the second adaptation then, let me just make sure I don't skip out on these. This is the first one. The second one would be the ductus venosus that I wrote out, which is, as I said, kind of a shortcut from the umbilical vein over to the inferior vena cava. Now, the blood is in the right atrium, so it has a couple of options. First, it could simply go down into the right ventricle, and some of the blood does that. It just goes right down into the right ventricle. And if it goes into the right ventricle, it's going to get squeezed, and once it gets squeezed, it goes into the pulmonary artery. This is my pulmonary artery over here. And we know the pulmonary artery has a branch over to the lungs on both sides, so we've got some blood going to one lung and some blood going to this other lung. But remember, once that blood kind of approaches the lungs, we have to think about what's going on inside of the lungs. So let me draw out what's happening then inside the lungs. You've got these sacs, air sacs, that actually are not full of air, right? Because when the baby is still inside of the uterus, or when the fetus is in the uterus, it's full of fluid. So you've got these sacs full of fluid, and going past them are little blood vessels. So this is a little blood vessel. Let's say this is an arteriole over here. Now, if it's full of fluid, that means there's not much oxygen. So what ends up happening is that there's a process called hypoxic pulmonary vasoconstriction. And what that means is that the alveolus literally tries to help constrict the arteriole. So the arteriole has some smooth muscle like this. And because there's no oxygen, the alveolus is going to cause that little arteriole to basically contract down. So it basically looks a little bit more like this. And when it looks like that, what we've essentially done is increase the resistance of that arteriole. And if this is happening millions of times and millions of alveoli, then the entire lung is going to have a lot of resistance. A lot of resistance in the lung at this point. So if that's the case, if there's a lot of resistance, then a few things we have to kind of deduce from that. The first is that if there's a lot of resistance, then the pressure in the pulmonary artery, remember this is our pulmonary artery right here, these two, I'll just draw a little arrow to both of them, the pressure in the pulmonary artery is going to go very high. So these pressures are going to be high. And that's simply because you've got a lot of resistance that you have to try to fight against. So they have a lot of pressure. And if there's a lot of pressure in the pulmonary artery, just think back and think, well, where did that pulmonary artery come from? It came from the right ventricle. So for there to be forward flow of blood, you better have a lot of pressure in the right ventricle. And then I could take the argument back and say, well, if you have a lot of pressure in the right ventricle, then you must have a lot of pressure in the right atrium. So you have a lot of pressure basically on the right side of the heart because of the fact that you've got a lot of resistance in the lungs. So these pressures, especially the right atrial pressure, starts getting so high that it starts getting higher than the pressure in the left atrium. And so you get a little bit of blood flow that starts going from the right atrium across that foramen ovale that allows, right here, that allows blood to actually go across it. So this is our foramen ovale. Foramen ovale allows blood to go from one atrium over to the other. And since blood can now go across, you're going to see some of the blood continue down into the right ventricle, but some of the blood will also kind of go across into here. And that's actually quite useful because at the same time that you have blood going across, you actually don't have too much blood coming back through the pulmonary veins. And the reason for that, again, is because it's hard to get blood flow through the lungs because there's so much resistance there. So you have a little bit of blood kind of coming in through the pulmonary veins, and you get some blood coming from the right atrium.
Okay, so we'll pause here. See where the foramen ovale is? That's a little flat. When they take their first breath and the pressure changes, it should close. Sometimes it's a little wonky for that first 24 to 48 hours, and that's what causes the baby to have acrocyanosis. Sometimes you will hear the term the baby was born with a hole in its heart. That just means that within that 24 to 48 hours, that did not close back over, and they will wait and see if it's not severe. Sometimes it will eventually go over in the first few months. If it doesn't, they can do a surgery and repair it, close it mechanically so it closed. If they're in dire straits and it's a big enough hole, they will have to do that surgery right away. So we do open heart surgeries on babies that are like a day old, sometimes less than a day old, depending on how well they're breathing.
Now from the left atrium, blood is going to go down into the left ventricle, and it's going to get squeezed around into the aorta. So now you get blood in the aorta that gets squeezed there, or sent there, from the aorta, or from the left ventricle. I apologize. So the left ventricle is squeezing blood down into the aorta, and the aorta is distributing blood all the way down. Now before I finish off showing you where the aortic blood goes, let's actually make sure I don't forget my list. Over here, my third adaptation then should be the foramen ovale. Foramen ovale, sending blood from the right atrium to the left atrium. And a fourth adaptation, actually, I've just kind of sketched out, but I haven't talked about yet, is right here. So you actually have this little guy right here. A little connection, a little vessel, you can think of it as a vessel because blood flows through there, between the pulmonary artery and the aorta. So this thing right here is called the ductus arteriosus. Ductus arteriosus. So the ductus arteriosus allows blood to go from the pulmonary artery to the aorta. And why would blood go in that direction in particular? Well, remember, the pulmonary artery, again, has very high pressures. And the high pressures are because of the high resistance in the lungs. So because of those high pressures, blood, of course, goes from high pressure to a place where there's lower pressure, usually. And in this case, it's going to go from the pulmonary artery over to the aorta. So it's actually going to flow in this direction. Let me just draw a little arrow. It's going to go flowing in that direction. So ductus arteriosus is another fetal adaptation. So we've got 4 so far. Ductus arteriosus. And this actually explains then why you don't get too much blood coming back through the pulmonary veins. Because a lot of the blood goes into the pulmonary artery trunk, ends up going into the aorta. It actually doesn't even go into the lungs because the resistance is so high. So now let's kind of wrap this up. Let's say blood is now down to the aorta, as I said. It's going to go into the legs, and it's also going to kind of go into these internal iliac arteries. So I've drawn these arteries here. These are the internal iliac arteries. And there are, of course, lots of branches off the internal iliac. But the important branch that I want to point out right now is this one. This branch, this major one that I'm kind of sketching in, this is actually we have a name for it, we call this the umbilical artery. So this is actually bringing blood back towards the placenta. Now, why would so much blood go to the placenta? I mean, that's a fair question. Why doesn't it go, there's a branch here that goes to the bladder, there's a branch that goes to other places. Why is blood going into the placenta branch or the umbilical artery? Why so much? Well, it turns out that the placenta, and this is very clever, actually has a very low resistance. Very low resistance. So just as the lungs have a high resistance, and they're kind of making blood divert away from them, the placenta has a low resistance, and it makes blood divert towards it. So you can see now that this is a really ingenious kind of system. We have these 5 adaptations: the umbilical vein, the umbilical artery now, we have the ductus venosus, and we have the foramen ovale, and the ductus arteriosus. I don't want to miss out on any of them. So we have 5 important adaptations here. And this is how blood flows in the fetus.
Okay, so what would I expect you to know from this video? Right. The adaptations. If I show you the video, it's not because I'm trying to fill up time. I didn't have anything better to do. It's trying to show you how the baby circulates in utero versus on the outside. And all of those steps have to magically happen after the baby gets here. They don't always happen right away. Sometimes it takes a few hours to a day or two for them to happen. But there are a lot of things that can influence the baby's ability to beat and breathe that we don't have control over. So we have to be very cognizant and very observing of the baby's ability to beat and breathe, to catch these things early on so we can fix them early on. Their reserves, their oxygen reserves, are very small because they have a very small blood supply, and blood is what circulates oxygen. So we have to catch them early. All right, so I might ask, where is the foramen ovale? Where is the ductus arteriosus? There's nice pictures in your textbook as well. Since we have a few people missing, and I'll never remember who was here and who wasn't, would the last person bring that back up to me so I don't forget it and leave it in here? Providing warmth, really important. If a baby gets cold stressed, it starts burning up glucose to try and stay warm. It has a limited supply of glucose because it got it from mom. It hasn't eaten yet, and they can get really, really sick and die. They have an unstable heat regulating system because that's regulated by your hypothalamus, and their brain is still pretty immature. Acrocyanosis is evident because of the sluggish peripheral circulation. It starts sending all of the body heat to the core to protect it. So it wants to protect the vital organs like the liver, the heart, the lungs, the kidneys. It'll send it inward, and the outward starts looking blue. Feet and hands and around the mouth. Cannot adapt to changes in temperature easily. When the baby's born, we put them underneath the warmer. They're a radiant warmer. So if we cover them up with blankets, the heat comes down, hits the blanket, and bounces off. The baby doesn't get warm. We need, it's sort of like a tanning bed. We need the baby out and exposed to the heat, the radiant heat coming from the warmer. What do the grandmas do when they see the baby laying uncovered? They bundle, oh, they're going to get cold. You can explain, no, we need to leave them open to it's like a tanning bed. The whole explanation I just gave you. If you turn your back, what is the grandma going to do? She's going to cover them back up. It's sort of innate in grandmas. And even though they know better, even though you've told them better, they don't buy into that. That baby's going to be cold if it's not bundled up. When we put them under the warmer, we put them with a sensor on. They're either, I've seen heart-shaped and I've seen teddy bears. And they have like a metallic finish on them with a wire that goes back to the machine. That's measuring their body temperature. The reason we do that is we need to make sure they're warm enough, but not too warm. If you leave them under the warmer too long, they overheat. You can have just as bad results. And you get busy, do another step, and you forget they're under that warmer, that tag has to go on them as soon as you put them under the warmer so that it will alarm when there's a body temperature issue. Sweat glands don't function during the neonatal period, so the infant is at risk for developing an elevated temperature if they're overdressed or placed in an overheated environment. So I love the way they pull the hat down over his eyes for the little guy. See around the mouth? Acrocyanosis. The feet are blue. The hands, I love how the twins are holding each other's hands. We had twins once in the newborn nursery, cried and cried and cried. We couldn't figure out how to get them to stop. And finally, I just took one out of the crib and put it in with the other one, and they shut right up. I was like, oh, okay, there's my bro. And next thing I know, I go in there, and one is sucking on the other one's nose. I took a picture and took it into mom. Babies are comforting each other. Temperature can be taken rectally or in the axilla. Here's the important part. Their little armpit has just a little bit of area. So what you have to do is kind of stick that thermometer in the little divot and then hold their arm against their body. They do not like having their arm held there, but that's the only way to get an accurate temp. We take the first one rectally. Does anybody know why? I don't think it's in your book. It tells us if they have a patent rectum. If there's, if it's grown shut, grown over, they're not going to be able to have a bowel movement. That's going to cause a big issue once they start eating. So we need to know that there's an opening to the outside. So we do a rectal temperature for the first one, and then after that, most of them are axillary. Pulse and respiratory rates count before taking the temperature because the baby, again, does not like its arm held against its body and will cry. You should report temperature elevations greater than 99.8 or less than 97.1. Those are your magic numbers. Have to know those. Pulse rates greater than 160 or less than 110. Respiratory greater than 60. Yes, they breathe at 60. They're still immature. Or less than 30. Any noisy respirations, the grunting or the gasping. Nasal flaring or chest retractions. So neonatal vital signs are assessed as followed. Axillary temp is 96.5, pulse of 125, respirators of 44. Which one of those are you aware of? If it's axillary, do you add or subtract? You add, good. And if it's rectal, do you add or subtract? There you go. So if you're the nurse that answers the phone at the pediatrician's office, is it important for you to ask, did you take it axillary or rectal? Yeah. Yeah. So the question included axillary as a hint to help you to remember to do that. So which one of those are you the happiest with? How many think number one? Nobody? Number two? 3, 4. It's 4. Temperatures decrease. So keep the head covered. It has a large surface area and it's the major area of heat loss. There's a reason we put those cute little caps on them. Don't let them lay where there's a draft over them because they lose heat by convection. Don't put them on a cold surface because they lose heat by conduction. Don't put the bed near a window because they have heat loss through radiation. Keep them covered at all times. Expose small areas when you're diapering or bathing. Neonate has a small amount of sub-Q fat to give it body heat. If it burns all that up, it's in critical condition. So on this this chart, it's talking about radiation, conduction, convection. So the state may ask you questions, and I might stick some in a test or your final that says, you laid your baby on a cold surface. What kind of heat loss will it experience? Conduction. So you not only have to know where not to put them, you have to know what kind of heat loss they will have. So their musculoskeletal system, their skeleton is way flexible. It's mostly cartilage. They don't start to ossify until about 1 year old. That's so they can mold and come out of the birth canal. Their movements are random and uncoordinated. Development of muscle control proceeds from their head to their foot and from the center out. So you will see them when they first learn to roll over. Do they put an arm out and roll over neatly? No, they go flop because they're using their bellies, kind of thing. So when my first grandbaby was born, Emma, we were up to visit, and it was like week 3 or 4, and they had her sleeping in her car seat. I go, why is she still sleeping in her car seat? Why isn't she in her bed? Well, she doesn't like her bed. I said, well, you can't let her sleep in the car seat. Why can't she sleep in the car seat? She'll have that major flat head, which was the thing that inspired my daughter the most. She'll have a flat head. She won't develop. They can't develop in a car seat. You can't roll over in a car seat. So she's not going to get the musculoskeletal development that she would get in the bed. So they really need to sleep in their beds. Their head and neck muscles are the first ones under control. If they're in a car seat and they're sitting up, do they have the ability to move their heads? Not like they would if they were in a bed. Average length, 19 to 21.5 inches. Average weight, 6 to 9 pounds. If you want to have the bestest delivery, go 6 pounds. If you want to have a more difficult, go 9. This week at the hospital, we had one gal, it was her 13th pregnancy. She had a 10.2 baby. She was a gestational diabetic that was non-compliant and didn't get prenatal care until 26 weeks. It was like, what can go wrong here? The baby had blood sugar issues. We had to do Q half-hour blood sugars on the baby. By the time our shift was done, that poor little baby's foot looked like a pincushion. Just trying to keep the baby in a safe range. In the first 3 to 4 days after birth, you should expect them to lose weight, anywhere from 5 to 10%. Usually breastfed babies lean more towards the 5, bottle-fed more towards the 10. Maybe a result of withdrawal from the maternal hormones, shifts in the fluids, and they start having feces and urine. Kidneys are not fully developed at birth. The glomeruli, the filters, are small. The renal blood flow is about a third of what an adult is. Their ability to handle a water overload is reduced. So, if the baby's born with blood sugar issues, we may give them an IV with glucose. We have to watch them very carefully because we can fluid overload really quick. The renal tubules are short and they have a limited capacity for reabsorbing the important things that we need in our bodies. So their body chemistry can get out of whack. Decreased ability to concentrate urine and cope with fluid imbalances. So what's our first sign that there's a problem with the kidneys? They're not producing urine. So we like to see a wet diaper in the first 8 hours. If we don't see a wet diaper, we're going to start doing some kidney function tests and see if something's wrong. Newborns should have about 6 wet diapers a day. I would go with 6 to 8. If they're breastfed, they usually have more towards 6. If they're bottle fed, more towards 8 because the breast milk doesn't always come in for the first couple of days. In the male genitalia, the testes descend into the scrotum before birth. So you need to palpate and make sure that you can feel that tiny little, feels like a little bird egg, is inside the scrotum. If you're just feeling soft, squishy tissue, that means that the testes are still in the abdominal area. What does that mean is going to happen? You can cook them. It's too warm in there. So they may have fertility issues later in life. Sometimes they will drop down on their own. So the doctors will wait and see if that happens. If it doesn't, they'll have a surgery to bring them down. Location of the urethral opening should be on the tip of the penis. Occasionally, little baby boys are born with an opening on the underside. It's a hypospadias. Every time they void, they pee on themselves. Very upsetting to the parents because it doesn't look right. Those babies will not get circumcised because they're going to have a surgery to fix that. And we use the foreskin to close the opening. So they'll get their circumcision, but they won't get it before they leave the hospital like the other baby boys. They'll get it when they're old enough to have the other surgery. And then we'll use that foreskin to close the opening.
What did you say that was called?
Hypospadias. There's a white cheesy substance called smegma found under the foreskin. Some parents may choose to have their child circumcised, others may not. It is not medically necessary to circumcise your child. What's the #1 reason that people do it? So they look like dad. If dad is circumcised, they want him circumcised. So that's the #1 reason. It does have some bearing on your risk of cancer as an adult because you need to pull that foreskin back and clean with soap and water several times a day. If we can't get grown men to do that, are we going to be able to get little boys to do that? No. And so they get infections. And anywhere you get repeated infections increases your risk for cancer. So if they get repeated infections, they have a higher risk of penile cancer later in life. That means that they will have to have their penis removed. That alone is enough to inspire a lot of parents to get the circumcision. Not our job to do the teaching. The doctor does the teaching. If they ask questions and we know the correct answers, we can answer them, but we are not supposed to be doing the teaching. If they're way off base and you think they don't have a rat's patootie what's going on here, you need to get the doctor back in there and do the explaining. Did you ever let a parent watch circumcision? No, only an idiot would do that. They'll tell you how brave they are on the floor in 2.2 seconds, usually with the first shot of light.
I had to watch one of Chronicles last week.
Yeah. So students really enjoy it. There's a few that you can see by their expression they're doing this thing. Okay, you're not probably going to do baby nursing.
They did it. Yeah, they got their start in the doctor's office.
Yeah. A lot of them, well, like at Plymouth, we only had 2 doctors that did them. So if you didn't have your baby on the day they were on rotation, then you just did it at the pediatrician's office.
I see that when they do tongue clipping. I see that too.
That's cool. Frenulectomies.
Yep.
Surgical removal of the foreskin on the penis is what a circumcision is. The benefits: decreased risk of penile cancer, fewer UTIs and STIs. So health maintenance kind of thing. Disadvantages: they can get infections and they can hemorrhage. If they hemorrhage, we can't let them go too long because they can't lose too much blood. We use a silver nitrate stick and cauterize it close. The nurse can do it. Disadvantages: far under the benefits. So most of the time when the parents see the list, they go, okay, I'm good with doing it. The infant must be physiologically stable prior to performing the circumcision. So if they're a poor breastfeeder, should we let them circumcise them? No. So I saw a nurse on the unit get into an argument with a resident over whether or not he was going to do the circumcision. And I'm thinking, he's the doctor, I'm pretty sure who's going to win. I was way wrong. She did not back down. She said, that baby has not been eating. We've had the lactation consultant in here for the last 24 hours. If you do the circumcision, the pain is going to keep that baby from eating, and we're going to have a really sick baby on our hands. He said, I'm going to do the circumcision. Just didn't even bat an eye. She said, perhaps you didn't hear me. We'll have a really sick baby, and I'm going to call you every hour on the hour when that baby's sick. And he goes, well, you feel pretty strongly about this. And I'm thinking, you are an idiot. She does this all day, every day. You're a resident learning to do these things. Listen to her. And pretty soon he goes, you know, maybe you're right. He started to think about it. He started to get a little bit worried, and he postponed it. Baby started eating, and the next day they did the circumcision. So, female genitalia may be slightly swollen. There may be thin, white, or even blood-tinged mucus coming out of the vagina. We call it their first period or pseudo-menstruation. It's caused by withdrawing from the hormones that it was getting from mom. So it got the female hormones, comes to the outside, doesn't have those hormones, and so just like when our hormones shift, they have the blood or the discharge. Clean the vulva from the urethra to the anus, front to back. Teach your moms to do it that way as well. And prevent fecal matter from entering the urinary meatus, leading to a UTI. Baby girls have a very tiny distance between those two structures. So any movement from back to front has the potential for an infection. And babies can't fight off infection. They don't have good, sound immune systems yet. One other thing they don't mention, those hormones in both boys and girls can cause swollen breast tissue. The nurses call them baby boobs. Sometimes you can even have a little discharge from the nipples. Parents always freak out, especially if it's a boy. Not to worry, as soon as the hormones are excreted from the body or absorbed by the body, that will go away. The skin system. Assess the turgor and overall skin condition. Usually they're covered with a fine hair that we call lanugo. That goes away within a week of birth. If they're African American, Hispanic, Indian, and have a darker hair color, darker complexion, you might notice they have sideburns or on their back and their shoulders. And parents wig out and say, you know, I've given birth to the ape baby. It's always going to be like that. It'll be gone in a week or so. They're covered in vernix, that waxy, looks like cottage cheese, but when you feel it, it's really waxy. What's the purpose of that? Protects their skin. In utero, they're taking in fluids and their kidneys are practicing. So they are peeing just a little bit. They are voiding a little bit. So they're floating in baby pee, right? And you know how caustic that is when they are in a wet diaper, how their bottoms can get raw? Their skin would get raw. They're floating in that. So the vernix keeps that from getting to their skin. So if you have a baby that's born early, they have a thick layer of vernix. If you have one that's born late, you'll have red peeling skin because all the vernix is gone and now the skin is irritated. Physiological jaundice, icterus neonatorium. You see it as a yellow tinge to the skin, sometimes yellow eyes, caused by the rapid destruction of excess red blood cells. So it got this rich supply of red blood cells from mom. It didn't have any trouble getting rid of them in utero because mom's liver took care of it. It comes out, its liver isn't mature, it can't break down those red blood cells, so it sends them up to the skin surface and the sunlight breaks them down. So if you have a baby that has jaundice, we may tell you for 5 or 10 minutes a day, put it near a window if it's not blazing sun or freezing cold, and let the sun hit on its face and shoulders, and that'll help the bilirubin. Your other